Hey, this is Laurel. Today we are going to be learning about the depolarization through the heart and how that relates to muscle contraction and relating that back to an EKG. We're going to look at the blood flow through the heart and relating that back to heart failure with HFrEF and HFpEF and the difference between the two. And we are also going to be looking at the difference in the imaging modalities seen when looking and assessing heart failure. So, beginning with depolarization through the heart, here we are able to see our SA node, our AV node. So this is where it all starts. The SA node sends depolarization down from this way in the right atrium. As you can see, they're labeled here. So the depolarization is sent from the SA node to the AV node. But when it hits the AV node, there is this line of dead tissue. So there will be an AV nodal delay that we will discuss in the EKG later, where you can see that. Moving from here, the depolarization is sent down to the bundle of His right here, down the bundle branches, and up through the Purkinje fibers. So that is the movement of depolarization through the heart. We are able to track this with an EKG where it all moves, and that's what we will be talking about next. And this is how we can see how the blood is pumped from top down, bottom up. This is the movement that we can see. Now looking at this, relating it back to an EKG, we can see that we have the P wave here, the QRS complex, and then the T wave over here. So right here, the P wave is known as atrial depolarization. So that's when the SA node sends the signal and the depolarization is sent down through the atrium. This is what I was mentioning earlier, right here. This is known as the AV nodal delay, where I said that because of the dead cells in that area where the AV node is, there will be a delay in the EKG. Then we have the QRS complex, which we can see ventricular depolarization. When the depolarization signal is sent down, the bundle of His, the bundle branches, and then once it is sent up the Purkinje fibers, we can see here at the T wave the ventricular repolarization, and then we have the isoelectric line over here before it all starts again. This signal will not be able to be sent to the muscle to allow for muscle contraction if it does not reach this threshold of -55. So once it meets this threshold right here, depolarization is able to occur, and then repolarization, and then hyperpolarization, and then the contraction is allowed to continue. So without this membrane potential being reached, the depolarization and the muscle contraction is not allowed to happen. So here with muscle contraction in the heart, the calcium and the depolarization is sent down the T-tubules. It's picked up by the voltage receptors, which can be seen here in the sarcoplasmic reticulum, which causes that to release calcium, which allows for the muscle contraction to occur in the Z-disc. This whole thing is a sarcomere. Something to mention about cardiac muscle, SERCA and phospholamban are here. SERCA works to bring this calcium that's dropped off here and used here, brings it back up and collects it here, and phospholamban is something that inhibits SERCA. So they work together but not for each other, I guess. So once this calcium is sent, the calcium binds to troponin C, which reveals the tropomyosin and allows the myosin and the actin to bind to each other, which is where we are going to see that muscle contraction and the power stroke from those two things. And this is the Z disc. So once we have an attachment, we can attach and attach. And one of them is ADP and one of them is inorganic phosphate. So when they attach, they do half a stroke and then half a stroke to get that full muscle contraction. And when ADP and inorganic phosphate combine, that creates the ATP that is then used to further the contraction, to allow for more contractions to occur, to allow for the signal to be sent, to allow for our muscles to keep contracting in the way that we want them to in whatever situation. So that is how all the muscle contraction works when we are talking about the depolarization sent all the way back to what we were talking about with depolarization through the heart and the membrane potential and the EKG. So yeah. So moving on with heart failure. Heart failure is when the body and heart cannot pump the oxygen and blood that is needed throughout the body and back to the heart. And as we learned in class, we can see that we have two different kinds that we learned about. There's HFrEF and HFpEF. This is heart failure with reduced ejection fraction, and this is heart failure with preserved ejection fraction. So the difference between these two, HFrEF is reduced ejection fraction, as I said, where the left ventricle fills with the blood, but it's only able to pump 40% of that blood before refilling. So it's not able to get all of the blood out of the left ventricle out through the body before more blood is pumped into that left ventricle. So that's the reduced amount with HFrEF. But with HFpEF, as we can see, it is preserved. So it's heart failure with preserved ejection fraction, which means the left ventricle has stiff and thick walls, and it can only fill a small amount of blood. So even if it pumps all of its volume, it's not able to meet the body's needs. The walls have become thick and stiff, so they're not as movable, not as able to get the blood out, but more than 50% of that blood in the left ventricle is still able to be pushed out of the left ventricle and throughout the body. So it's not as low of a ejection fraction as HFrEF. So we get more blood pushed out with HFpEF than HFrEF. So that's the difference between these two types of heart failure. And then now we're going to move on to imaging and how we can see these different types of heart failure and help those patients. So I'm bringing out this diagram so it will hopefully be able to explain the blood flow through the heart so we can better understand how heart failure happens and how we can relate it back to HFrEF and HFpEF. So we're going to begin with the blood flow through the superior and inferior vena cava, which come into this right atrium right here, go through the tricuspid valve into the right ventricle. Then from there, it's going to go up here through the pulmonary semilunar valve and the pulmonary trunk, and then the pulmonary arteries, which go to the lungs. And then from the lungs, the blood is brought back through the pulmonary veins, as we can see on either side, and it's brought into the left atrium. So from the left atrium, It's going through the bicuspid valve into the left ventricle right here. And then it's going to move up this way through the aortic semilunar valve. And it's going to move its way through the aorta and then out through these veins here. It's going to go into systemic circulation. So hopefully this explanation of blood flow through the heart better equips you to understand what heart failure is and how the blood flow through the heart affects our heart, obviously, and shows the difference between HFrEF and HFpEF. Lastly, we will be discussing imaging modalities that will help us see heart failure and see where the heart failure is occurring, how it's affecting the body. So first we're going to begin with the PET scan, which is able to detect areas of your heart muscle that are receiving enough blood, if there's heart damage or scar tissue or buildup of abnormal substances. And it does that by giving a tracer through an IV. The tracer travels through your blood and collects in the organs and tissues, including your heart. Because we are looking at the heart, that's what we want to be seeing. The tracer helps the radiologists see those diseases more clearly and see what they're looking for in heart failure. There will be an ECG placed on your chest, and the computer is able to give 3D images of the heart based on the tracers and everything and all the picture takers, and those images are then displayed on a model or a monitor for the radiologist to read. So yeah, that's how a PET scan works. Moving on to a nuclear stress test. This is basically the same idea as a PET scan. For the nuclear stress test, you are given a small amount of radioactive material called a tracer, or a radio tracer. It's given through IV, and then once that tracer is moving through the heart, moving through the arteries, the pictures that are being taken are able to find poor areas of blood flow and damage to the heart. This can be done after a heart attack, before a heart attack, just coronary artery disease, which we will be talking about in my next video, but that's how those work. They're very similar to each other. Moving on to a stress echocardiography. It's a test that uses ultrasound imaging to show how well your heart muscles are working to pump blood throughout your body. It's often used to detect decrease in blood flow to the heart from narrowing in the coronary arteries. So seen with coronary artery disease. This is a easier way to test for coronary artery disease or heart failure. Easier than these two. And then moving on to the cardiac MRI. This is very similar to any other MRI, just based on your heart. And MRIs are able to look at the softer tissues, and it is able to detect heart failure or tissue damage due to a heart attack. The MRI can also detect if muscle is alive or dead. Using the MRI, it will show either white or black, depending on how your heart is looking, how those different parts of the heart, based on your heart attack, based on your CAD, based on anything. So that's how all of these imaging modalities work to help image the heart and detect for heart failure, CAD, effects of a heart attack. That's how all of those work on the heart. So in this video today, we were able to look at depolarization and muscle contraction through the heart, looking at the membrane potential graph, seeing how depolarization works through the muscles and how it has to reach that threshold. We looked at depolarization, looking at it through an EKG, how it relates back to the depolarization through the heart where each thing happens. We were then able to look at heart failure and how that happens in the difference between HFrEF and HFpEF. Looking at heart failure, it's easier to know the blood flow through the heart, so then we went through the blood flow through the heart, and then we ended with looking at the imaging modalities that doctors use to see what the heart is looking like after a heart attack with cardiovascular issues, coronary artery disease, with all of these things. Those were the imaging modalities that we were able to use and learn about through cardiovascular viz. Thank you.